You're listening to Finn Voices on Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation. Innovation that improves people's lives. Join us for an inside look at the changemakers driving conversation and answering the most important questions in healthcare today.
Welcome to Finn Voices. I'm Beth Friedman, Senior Partner at Finn Partners, and today we're digging into a tension that every health system feels, and that's the gap between technology and the nurse's reality at the bedside. My guest is super excited to have DJ Tucker on with me today. She's the Managing Director of Health Informatics at Healthcare IT Leaders. She spent 25 years as a pediatric nurse and also a pediatric ICU leader before moving into the, I'll call it the dark side, the IT vendor side of our industry, where she has also spent a lot of time at Cerner with implementations, but then also working now at Health IT Leaders as, a consultant, advisor, strategist. So she's helped with lots of hospitals and worked with lots of EHRs. DJ, welcome to the show.
Glad to be here, Beth. Thank you.
Absolutely. So before we get into sort of the how-to of nursing informatics, which is your area of expertise, I do want to go back to, there was a point in your career you told me about when you saw how the technology, I'm assuming we're going to talk EHR a little here, looked great on paper, but maybe not so much in nursing practice. I think that's when you made that decision to jump from hospital to IT company. So tell us about that.
Sure. So I'll date myself a little bit. So early 2000s, I was a ICU nurse manager at a hospital on the West Coast, a very busy level 1 trauma center. In the Peds ICU, we were reviewing and evaluating EHRs. And at the time, our organization had decided to move forward with a large vendor. So back in the early 2000s, I was a Peds ICU manager at the time at a very well-known children's hospital on the West Coast, level 1 trauma center with a very busy Peds ICU. And during that time, we were evaluating EHRs and trying to figure out how we could do our work better and faster. We were really, at the time, focused on codes, how we could document codes when kids were coding or rapid responses, et cetera. So us, the Peds ICU and the CV ICU worked together to really say, is this going to work for us or is it not? And we actually decided not to implement in the ICUs. We were using an old antiquated system called CareView. And the reason that we really didn't jump to this new EHR was because it just wasn't capable. At that time, the technology really did not support the work of the ICU nurses and the way that we needed it to, but more importantly, it couldn't support the pediatric nursing specifically required to do our job. So, when I talk about that, I'm really talking about the weight-based calculations, the way that we cared for critically ill children, the demands and level of specificity that general platforms often missed. Kids aren't just little adults, and that continues even in 2026 to be the case where we often, from a pediatric perspective, have a miss. So in that, it's really that the technology wasn't there. It just didn't meet the needs of what we were doing.
Right. So I'm just imagining this scenario, right? Back in the early 2000s, I was there too, at that same time, right with you. IT often has one agenda, right? They want to get this installed, they want to get it in. But to your point, I really respect the fact that your team stood up and said, no, it's not ready for prime time, at least not in our department, right? At least not in our unit. I'm just curious about this. How did IT reply or respond to that back in the day when you had that conversation?
I mean, they weren't happy with us because then what that meant was then they had to figure out how they were going to integrate, right? Provide interfaces. So I think from that, it was a harder challenge, but it was doing the right thing for the patients and keeping them safe. And that's something that I've really carried with me in my, from my career forward, is that it's never that question of can we implement this? It's really about should we, which carries a ton of weight. And you'll often hear me say, hey, if it's not important for the patient, the caregiver, or or specifically the organization, then why are we doing it? Why are we paying for this?
Yeah.
And so, yeah.
So that lesson sounds like it served you well, because probably you do that today still, right? With your clients and the people you consult with, as they're looking at new technologies, making sure that it's not just checking the box for an IT implementation or go live or optimization even. It's making sure that the end users are going to benefit.
Yeah.
So how did that experience, or how does it even today, shape your conversations with your current customers and with the nursing teams that you work with?
The way in which that has served me today is that I'll give you a little background. So, as you've indicated, Beth, I went to the dark side for many, many years. And during that time, I had to stay within some rigid lines of scope when we were dealing with our frontline customers and they wanted to pay for X and we were supposed to deliver X. We really didn't consider all the upstream and downstream impact that would have on an organization. That impact that it had on those organizations before were, hey, we paid for this, you dropped it off, we're still not getting the expected outcome of what we should be getting. So now today, fast forward into a different type of role. With those lessons learned, I am free to now say, I can draw a line in the sand and say, look, you haven't considered what's going to impact you upstream and downstream. And so when I ask the question, have you considered the patient? And we work backward from the patient or the caregiver. Oftentimes the answer is yes. And I say, quote, yes. But we know that when we start peeling back the onion and asking more questions, they really haven't thought about how that's going to, i.e., impact, if it's an acute workflow, how it might impact referral or something out in the ambulatory, vice versa. Ambulatory projects, still those orders still go to inpatient or could follow that patient. So there's many reasons why we still have to always continue to ask the questions throughout the entire process, and really it be a guiding principle, quite honestly.
And, I can only assume the nursing leaders, nursing informatic leaders, chief nursing officers, the unit directors, they must truly appreciate your experience and your insights when it comes to this. Because, we've seen health systems spend billions on their EHRs and other systems, right? Not just EHRs. So for that nurse that's still standing in that disconnect, and let's say the system gets implemented and they didn't take that pause that you're suggesting. What's that feel like for that nurse, at that bedside?
Funny you should ask. So this is like a pet peeve of mine. And I think it's because we just can't seem to advance the way in which we deliver, right? We can't seem to advance the idea of really integrating nursing into everything that we do. And that doesn't mean bring them in the middle, doesn't mean bring them in the beginning and ask a question and not let them go through the lifetime of preparedness and requirements that are needed for them to really understand upstream and downstream. What's important is that we as consultants or nursing informaticists ensure that an organization has a foundational understanding of what it means to involve their informaticist or nursing during the process. Why that's so important is that I think it's great when we're at the table, but then maybe we're not part of testing or vice versa. Maybe we weren't at the table at the beginning. Now we're part of testing and we're asking, well, who made this decision? Don't you know this impacts X workflow? We really haven't made big strides in this area in 2026.
Wow.
And so as part of as a consultant, it's my job to go in and say, look, we have to really make this worthwhile for the person that's delivering the care to the patient. We continuously are battling attrition. We're continuously battling cognitive burden, overload. Well, maybe that's because we continuously make it harder for the person that's delivering the care to the patient. And so going back to that question, it really is about how do we keep the nurse involved? But more importantly, even a step before that is not just putting a nurse in there to answer the questions, but someone that's ready to actually also question and downstream. And I have a quick example I would love to share with you because I think it really drives the point home.
Okay.
And that is that one of the implementations I was involved with, they had asked for SME. Okay. So we gave them like best of the breed. She was someone who was extraordinarily skilled in ICU workflow, had been at this organization for many, many years, so knew the ins and outs, how things worked, and could answer anything. She was a big resource to the organization. So we're like, yeah, well, here, use her, right? Well, that was all great, except that when she got to the table, which step one, we got there. And step two, she was skilled in her own workflow. But number three, from a foundational perspective of being the empowerment of being able to actually use her voice, I think was missed. I think we, from an IT perspective, we get they get nervous about asking us questions. And then as a nurse, we're like, well, we don't want to overstep our boundaries, or we don't want to. And so there was these unfortunate misses, right? Because you had the right person at the table, yay, but we couldn't really we didn't get her into a place where she felt comfortable pushing back. And that's, if you can't push back in a workflow to say it's not going to work, and then we let it keep going, it's only going to be that rolling stone gathers no moss, or whatever that thing is.
Yep.
Well, it gathers a lot of moss and it gets really broken. And by the time it comes to testing, we could have avoided all of that time of people and money. And so I'll stop there because I get on these tangents about this because there's so many components, not just being at the table, but are you skilled to be at the table? Are you bringing the right quality and information to the table that's going to be helpful in what we're doing? And can you bring different lens to the table, right? It's about, we always talk about, hey, bring that naysayer. This is one of those times where sometimes it's nice to have those people that are always like, because they see so much more than what we see in workflow. And I think the other last little nugget there is that when we talk about workflow, oftentimes people are like, well, what do you do? And I have to say, let's talk about meds process. Okay, fine. So how do you give meds? Well, I barcode scan, I check my patient, make sure I have the right drug, the right time, for the right patient in the right bed, right date of birth. Perfect. Great. And then they give us all these other steps. But what they failed to do is that didn't start there. The process really started, well, the doctor decided you needed this med.
With the order.
So now we have a partial workflow that I'm a really good expert in and can articulate it well, but I haven't given you an end-to-end workflow. So now, we continuously are automating partial workflows and then wondering why the heck, when we get to testing, that it's not working.
Is that what you mean when you talked about upstream and downstream? So upstream in that scenario might be the physician placing the order, right? Like, where did it start? Downstream is with that nurse documenting what he or she did as far as the medication administration. It's like, you're right. There's so many steps. And I like what you mentioned too about being, I don't know if it's naysayer, but just raising questions, like asking the questions, being at the table. There's so many tables. I think about an implementation, right? There's the upfront, there's discussion, there's the planning, there's the testing, there's the rollout, there's the go live, there's the training. So you've taught, so all of those tables, I guess, have handoffs, right? So there's different handoffs. And I can only assume that if we have to change teams or use different people, then it's even more complex and more confusing. So how can we, I guess, thinking about it, how can we do a better job with those handoffs during these implementations when it comes to, that very beginning with the IT going all the way down to the end users? What are your thoughts there?
So just to clarify, are you talking about handoffs like within workflow, or are you talking about handoffs of getting the right complement of team to the table?
I'm talking about like the different steps in the implementation process, DJ. So, like when you're going from the design to the testing to the go live to the rollout to all those different kind of phases, it seems to me that the teams have to hand things off to others, maybe, or is it all the same team? It's been so long since I've been involved. It might be a silly question to ask.
I don't think it's silly at all. And I think it's, Beth, one of the biggest pitfalls that we have. I think that just like in medicine, a patient going from the ED to the ICU, we expect and have this great idea that this is going to be, when you tell me something, okay, that's it, and we move forward. But we know when it comes to medicine and transitions and handoffs, that doesn't go so well, right? We don't have the right tools in place or the right communication in place. It may involve devices. Same thing when we're going through these phases. I think that when we are, infrastructure is key. The best laid plan, right, always has failed. And it's okay that it has failed. And we should know that with humans, there's going to be fail. However, what we don't do is we don't check ourselves. So from a handoff from design to the next of build, right? That whole idea of checks and balances, right? Mm-hmm. If I have a nurse sitting at the table and I'm giving you this information, and now the analyst takes it and now is putting it together. And then the next point is that we're going to do a little testing, right? We're going to ask a little bit more questions, and this, that, and the other. What we kind of have unfortunately done is we've tried to go faster. Mm-hmm. And as a byproduct of going faster, Beth, is that we've missed the integration piece of this. So you captured my view well. And again, thank you for bringing me to the table. But what you didn't do, kind of going back to that same scenario that I just was talking about, partial workflow, is we really didn't bring in the doctor, and we didn't bring in the ED, and we didn't bring in, radiology or discharge planning to talk about what a process end to end looks like. So you've heard my point of the story as a nurse, and this analyst is doing great work and now has built my part as a nurse. But have they then gone, did they go to the physicians and say, okay, what's your part? Mm-hmm. And then when they build, did they build in a silo? Oftentimes, yes, because when we get to testing, that's when we see failure. Because oftentimes it's those integration points, and it's all because we didn't hand off well. But it goes even further back than that, is that we didn't put, again, that infrastructure in place to have not just DJ Tucker at the table to discuss nursing, but to have an integrated session with DJ Tucker, and Dr. Beth and this and that and the other, right? So handoff, they're critical. Mm-hmm. What we don't do is build governance in there that says, have we successfully checked the boxes, and what does that look like? And then let's check our checks, right? We got to have governance to govern what we're doing. And I think that's where we're going to continuously miss and cost more, and have these other things that are happening to organizations that really, frustrate them, and it's just devalue, right? They really won't be able to get the value out of what they've purchased.
So we've talked a lot, DJ, about sort of this implementation piece, go lives, testing, things like that, making sure what I've heard from you loud and clear, nurses involved at every single stage, clinicians involved in the pieces that they touch and in their workflows, and also making sure our communication, our handoffs are best case scenarios, and that there's checks and double checks all along the way. So some great advice from you. Let's fast forward. We've put in the EHR, or the new system, could be a new AI nursing application, right? I think people are going to try and go fast and furious with all this. Vendor's gone. IT's in charge of this. the nursing department, the IT department have that long-term relationship. How do we sustain the nurses' optimal use of these products over time through training, education? It's not a once and done, right? It's a long-term relationship between that organization's IT department and that nursing team. So any advice as a consultant on what we can do to make that relationship better over the long term, and not only make then, I guess, system utilization better, but nurse satisfaction better?
So I'm going to scale back a minute and really talk about nursing.
Okay.
And why we're here and what we're here to do, right? What were we called to do for nursing? And that's really to provide care and compassion to our patients, right? I think that the question of AI and all these tools and the shiny pennies that we're continuously seeing come our way are great. I think that there's a place for every one of them. But what I always worry about is that we are oftentimes, from a nursing perspective, forced to use those shiny pennies in a way that really may not satisfy the need for the care that I deliver. And again, going back to, from a satisfaction perspective, you've provided me with a tool. Does it work for the organization? Great. It probably looks great and does well for some other unit, but maybe not mine. Maybe not in the way that I care for my patient. Does it work for me? No, it's actually taking me longer to do it. Maybe it's safer, but it's taking me longer. And in the long run, does it actually benefit the care that I deliver to my patient, right? So having said that, I believe that there's still a big opportunity for all of these. However, because we're caring for patients in their most vulnerable moments, and all of us get busy, right? And there's a story behind all these curtains. I've cried with parents. I've fallen to the floors with families. I've sat with families and sung songs. I've had dance parties with patients. But those moments, are not separate from nursing. They are nursing. They are nursing. And what it means for us to show up. So when I talk about technology here, there's a story that we heard at Vive where the nurse is going down a return patient back to the OR, and the patient says, "Hey, can you stop and pray with me for a minute?" And fortunately, this organization actually had implemented an ambient listening tool, which actually captured that moment. And so in that moment, we are now able to document a spiritual intervention, which oftentimes these are things we do daily, but we don't capture them. So from a tool perspective, that worked, right? However, it's a compassion story that really technology has made more visible, right? We had the presence of mind to, and enough emotional capacity really in that moment to stop and be human with that patient. Mm-hmm. But the real threat is deploying technology without nurses at the table to tell you which parts of that can work, which parts could be automated, and which parts should never be.
Yes.
Really. Yeah. So when nurses aren't part of that conversation, we lose both, right? And that's where we are going to continuously see attrition and burnout and less satisfaction. Lastly, I think what's important here is that we have a gift, and I believe this technology can really help us provide an even bigger gift to our patients by providing us more time. If we do it the right way, it's not about that technology has really hindered our compassion. What it does is it depletes us of that compassion, right? It doesn't, I said that wrong. It doesn't deplete us of the compassion. The compassion's there. What it does is I am so tired that I can't go and deliver the care in a way in which I really want to at a patient's most vulnerable time in the care.
So it sounds like if you had some advice to give to CIOs and other IT directors putting in some new tech these days, It will be, don't forget about the patient. Don't forget about the compassion that the nurse has as a
Indeed.
professional. That's why you all went into the profession. In fact, I think when this goes live, DJ, is right around May. May is National Nurses Month.
Oh,
So
good.
the reason I wanted to have you on the podcast is to celebrate nurses, but really to just remember that, to remember that that's why nursing professionals did the training and went into the careers and we spent time at college. The reason that they did is because that's what they want to do for patients. And let's not overburden them with the technology that kind of gets in their way. Let's not let the technology get in their way.
Yeah, like I said, I love AI. I use it every day. I love nursing, and I believe there's a really great place and a great balance there. We're going to continue to see all these shiny, I can't say really pennies anymore because, but having said that, I think what's important for organizations to understand is that, everybody is working really hard to do the right thing, and we all get really busy. But I think if you can use some guiding principles like thinking about the patient, thinking about the caregiver, not just nurses, it's all care deliverers, right? Sure. We're just really accustomed to having it shoved down our throats. And I think the other point that I want to make and remind folks is that, when we don't bring them to the table and we talk about satisfaction and you want to turn the ship around, you're talking about the largest workforce in healthcare. So you may want to kind of get that right, and you'd probably yield a different result in doing so.
Certainly. Well, this has been so insightful and just good conversation. And again, giving me so much more appreciation for everything you and your profession does as an IT consultant, but more importantly, as a nurse, DJ. Thank you for all your service. Thank you for reminding my listeners that implementation, whatever tech we're talking about, go live isn't the finish line, right? It's almost just the start. And that keeping everything in mind that we've talked about, but also go forward, keeping everything in mind as far as the nurses and the compassion they want to give to patients. That's really the end of the day, the goal. You can connect with DJ on LinkedIn and learn more about her team's work at healthcareitleaders.com. DJ, thank you so much for being on the show.
Thank you, Beth. I really appreciate it. Thank you so much.
Have a happy Nurses Month.
That's what I was just going to say. Happy Nurses Week and Month.
Thank you again.
All right. Take care.
This has been Beth Friedman, Senior Partner at Finn Partners. I thank you for listening to Finn Voices, where we talk about health information, health innovation, and all the technology in between. Until next time, wishing you all the best in health.
Finn Voices is brought to you by Finn Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact for the world around us. Learn more at finnpartners.com and follow us on LinkedIn at Finn Partners.